All right, it looks like it's just about that time. Hi, everyone. Welcome to the Fall Voice webinar series. We'll be discussing today interdisciplinary telemedicine in the COVID-19 era. We thought this was a pretty timely topic considering the adaptability and flexibility needed to take care of our patients right now, and that includes the use of telemedicine. We have a great group of speakers. Let me begin by first introducing myself. My name is Lisa Zughni. I apologize for any confusion. I did just get married a couple of months ago, so you may see my other name, Lisa Doyley, floating around out there. I am the speech pathology supervisor in the Department of Otolaryngology here at the University of Washington Medical Center. I'll be moderating tonight's webinar along with my laryngology partner, Dr. J.P. Giliberto, assistant professor in the Department of Otolaryngology, also here at UW Medicine. And we're also joined by our expert panelists, including Dr. Jeanne Hatcher, assistant professor in the Department of Otolaryngology, Head and Neck Surgery at the Emory University School of Medicine, along with her speech pathology partner, Dr. Amanda Gillespie, director of speech pathology and co-director of the Emory Voice Center. And lastly, we are joined by Dr. Adam Rubin, who is the director of the Lakeshore Professional Voice Center and vice president of the Lakeshore Ear, Nose, and Throat Center. Welcome, everybody. Thank you for joining us.
Thanks for having us.
Great. Before we begin, I want to throw out just a disclaimer real quick that none of us necessarily claim to be experts in the subject of telemedicine. However, we've learned a lot very quickly, I think, and we are just here to initiate the conversation, learn from each other, and hopefully broaden all of our vision for the use of interdisciplinary telemedicine in our practices. If you have any questions along the way, you can use the question and answer toolbar, and Dr. Michael Johns, the one and only, will be fielding those questions from the audience as we go. So to go ahead and get us started, I wanted to talk about telehealth in general. And the term telehealth is this kind of overarching umbrella term for providing healthcare to a patient at a distance through the use of technology. There are other terms under the umbrella, including telepractice, which is the term that ASHA has adopted to incorporate more settings than just the medical setting. And for the purposes of this talk, we're going to be talking about telemedicine, which is the direct, synchronous, interactive care of patients using a telecommunications infrastructure. I also wanted to go over different visits under the umbrella of remote care. So we all know the normal phone calls we always use for our patients just to communicate and follow up. But this is different from an actual phone visit. A phone visit is a scheduled visit and it can be billed. There are different physician and non-physician telephone visit codes you can use based on the time that you spend on the phone with the patient. And that's separate still from a telemedicine visit. And that's what we're going to be focusing kind of our webinar on tonight. And that is a scheduled visit through the use of audio and video. And this is billed more in line with our in-person appointments based on the services we're delivering. So we might use our normal E&M codes, CPT codes, typically with the use of a modifier, but you will have to talk to your billing and compliance office or practice manager to talk about which modifier you would need to use for that. And so I also wanted to get into the ever-changing policies, rules, and regulations regarding the use of telemedicine, both before the COVID-19 outbreak and as well as what changes there are during the pandemic. So this is not an exhaustive list, but some of those changes are, before we did need to demonstrate patient needs. So patients that lived in rural areas or had transportation limitations, that requirement has been waived. We also could only see our patients for telemedicine who lived in the state where we have active licenses. There are state-specific waivers allowing you to do interstate telemedicine currently. And our telemedicine providers used to have to deliver services at the clinic or hospital. There is not a restriction on this right now, so we are able to provide telemedicine from home as long as it's secure and private connection, just so we can adhere to the physical distancing requirements needed right now. And there also used to be a restriction on new patients. We could only see patients we had an established relationship with. And right now that rule is not being enforced. So you can see all of these loosened regulations have allowed for a more widespread use of telemedicine at the moment, which has been great during the pandemic. One thing I do want to mention, though, is that although these relaxed rules are pretty clearly defined for our physician colleagues, there's quite a bit more ambiguity for speech language pathologists, particularly under CMS guidelines. Although we do have some voice evaluation and therapy codes which have been approved for use of telemedicine under CMS, we are not recognized providers for telemedicine. So I do want to point that out so that you are aware when you are coming up with your telemedicine policies and procedures to be aware of that kind of ambiguity for now. I know that ASHA is working very hard to change that. So hopefully that won't be so ambiguous in the near future. But in the distant future, or I hope not so distant future, when COVID-19 pandemic has subsided, it'll be really interesting to see whether these changes become permanent or whether they were just temporary and how that really changes the landscape of healthcare for us. And so, as I said, these regulation changes are really happening rapidly and day to day, to be honest. So the best thing you can do is be aware of the resources that are out there for you. Both the American Academy of Otolaryngology Head and Neck Surgery and ASHA have pretty clearly outlined on their websites different telepractice resources to use during the COVID-19 pandemic. So if you have any questions, it's best to stay up to date by going to those websites. So now that I have, I think, bored you all with all of the regulations, I do want to go ahead and hand this over to Dr. Giliberto, and he's going to go into some more of the specifics regarding patient requirements and provider requirements for logistics and the actual implementation of telemedicine in the clinic.
Awesome. Thanks, Lisa, for getting through all the tough stuff. We thought we'd take some time to say, what's necessary for the patient and provider side of things. And for patients, it's pretty simple. They need to have a device for which they can have both audio and visual communication with their provider. And they need to have a connection to the internet. You can do it over cellular, but broadband connections often work best. And there needs to be some form of electronic communication to get the patient to the telemedicine or telecommunications client. Typically that's the patient portal or the email, but you can also use SMS and texting. But there are some concerns about HIPAA security. You want to just make sure that you know what you're using to communicate with your patients. And then as Lisa beautifully talked about, there are a lot of evolving billing requirements. So you want to make sure that those patients fit into what you are able to treat for telemedicine. It's also helpful, but not necessary, to have a sort of a quiet private room that the patients can do telemedicine from. I mean, I have heard of some patients driving to the parking lot of a McDonald's so that they can get adequate signal. So, it's really up to the patient what they consider quiet and private. And we do ask our patients to have a thermometer. Documenting a temperature can be helpful for the visit. On the provider side of things, the requirements are very similar. You still have to have a device that has a front-facing camera as well as audiovisual capabilities, and you need to have a teleconference platform. We use Zoom like we're using here for this webinar, but there are many other examples that people have used successfully for telemedicine. There are too many to list and to get into the details, but the American Academy of Otolaryngology Head and Neck Surgery has a very good podcast that goes through some of the differences of these clients. So the nuts and bolts on the provider side are not that difficult, but having a process to streamline the workflow is pretty important to have an efficient and effective telemedicine program. This is a bit of a busy slide, but it brings together our whole department's telemedicine workflow to help streamline the process and make sure that our clinics run effectively. The first point of contact with the patient is at scheduling, either in person or on the phone. And we want to make sure that the patient meets those requirements that we talked to. We also want to update their clinic, their contact information, their email address, and make sure they're on the patient portal. And then 1 week before their appointment, we have Epic and we use Zoom. So we send them an electronic invite to their telemedicine conference through their patient portal or MyChart. We also have a phone check-in 15 minutes before the appointment. And then we have the Zoom and the Epic are not yet linked, although coming soon they will be. So we have, through the telemedicine platform, we communicate and talk to our patients, and we document, bill, do follow-up, and do patient instructions in the electronic medical record. Now, this is just one way of doing it, and I'm sure that many of the other panelists are doing it differently in their institutions. And actually, Dr. Hatcher, I just wonder, how are things different at Emory in terms of the client and the what you guys are doing for getting the invites out for telemedicine?
Yeah, absolutely. So right now, each provider goes through their schedule to see which patients would be appropriate or not. Our patient care coordinator or scheduler calls them to see if they have the capabilities for it, make sure that they're okay with that, and that's something that they would want to do. And then preferably through our patient portal, we get them set up with Zoom. Alternatively, if they're not set up, we will email them, but then we try and say, well, you can use your email to sign up for the portal, just that way it stays all, obviously in the same place. And then similar as everybody else, it's an evolving thing. What started this week was our medical assistants call the patient about a half hour before. Hopefully they will start to do their own Zoom appointment to kind of troubleshoot all the issues. Right now it's just a phone call to, make sure they're good. But it's working, and asking for medications, doing basically the usual check-in aside from vitals.
Right. How about you, Dr. Rubin?
A lot similar. We go through our schedule, actually we have to make sure there's anyone who, may have to be seen in person if we're going to, high risk or more urgent issues. And then everyone's pretty much offered a telemedicine visit. The important thing to do up front is to ask them what they have access to, because some people only have access to a phone or an iPhone, or not everybody has a computer. So so that's something we do. And then similar to what Jeanne talked about, is our MAs will call or Zoom to do an intake, get past medical history and things like that. And and all new patients, they're not flocking in at this point, but they're all offered telemedicine, and I think it's actually really nice. I mean, in terms of making a connection with the patient and letting them know you're there. And well, I'm sure you'll talk more about that, but we can. Right.
Actually, it's a perfect segue. We were gonna just now sort of transition into show how we use the interdisciplinary model in the Zoom clinic, which we're not going to bog things down too much by getting into a Zoom within a Zoom. But we thought we'd provide a bit of an example going forward. If you can advance, Lisa. There we go. Great. All right, so this is our Zoom client here, and so we'll get started. We'll see that Lisa's in our waiting room with our speech pathologist. So next, what we'll do is take this opportunity to talk about the next patient who's coming in. If there's any, specific things we want to talk about from our previous encounters with the patient or outpatient records, and then we'll see that our next patient has joined us from and is in our waiting room. So we'll admit her from the waiting room, and again, it takes a couple seconds for this to reload, and then we'll have a 3-person view. Hi, Emily, how are you?
I'm good. How are you?
Great. And then we would conduct our multi-interdisciplinary visit as we normally would, asking her questions about her history and her and what her chief complaint is. We can also take this opportunity to share our screen and patient instructions that we might have ready for the patient about medications or what have you. We can also go over radiology results, where we can go over MBS findings, and we can all sort of interact and discuss what was found. Finally, we can even use the whiteboard function to go over some drawings, particularly for surgical planning, or to go over some findings on a previous stroboscopy, and that way we can sort of all be talking and have somewhere to draw and discuss some of the complex issues. In addition, once we've sort of conducted our initial evaluation, we can take Emily and we can just, Emily, we're going to talk about you a little bit behind your back, if you don't mind. We're going to put you back in the waiting room. We'll readmit you when we're ready for you. And so then Lisa and I can have a conversation.
And we can also use this, we can talk about our thoughts in front of the patient as well, depending on the situation. But this is a nice feature if you do want to have a conversation without the patient in the room.
Exactly. That way you have flexibility to do both things which you would do in an in-person visit. And then when we're ready, we can admit Emily back into our visit. And then, all right, well, we've had a chance to talk, Emily, and, you know, here's what we think is going on, and here's what we like to do going forward. Does everything sound good?
Sounds good.
Excellent. Thanks. We'll get you set up for your follow-up. We'll have our MA give you a call. And at that time, we can remove Emily. And before our next patient.
Uh-oh.
Oh no, it just cut off that way. We just started getting a little too into it, but basically it gives you a general idea of how the visits can work and can be pretty functional. So thanks to Emily, one of our other speech pathologists, for helping us out with that. So now that you all know how to do a multidisciplinary visit, it's important that all of us providers get onto the NSDA's website to update our listings to let everyone know that you are giving or providing telemedicine options. With that, I think I'll turn it back over to Lisa to get us into our panel discussion.
All right. Thank you very much, JP. That was very, very meta, the Zoom within the Zoom. Let's go ahead and get started with our panel discussion. Our first question is, what does your interdisciplinary telemedicine evaluation look like? Are you doing interdisciplinary telemedicine? And if so, let's start with you, Dr. Hatcher. What is your setup at Emory?
It actually looks very similar to what y'all were just showing. And when we first started this, I guess it was last week, Amanda, we kind of had like the speech pathologist has their own Zoom and we have ours, but then we were just chatting on Monday about, yeah, let's just all be in my Zoom account and then go from there.
That sounds great. Dr. Rubin, how about you? Have you had this set up? And
well, we're not quite as ashamed to say as interdisciplinary at the initial visit if you're talking about new patients, but we're discussing constantly. So if I have a new patient, I'll see them, and most of this is just practicality. And in truth, our voice pathologists now are doing quite a bit of teletherapy, so they're usually typically, so coordinating everything gets a little complex. But typically, particularly for a new patient, I'll see the patient first, and then we'll set them up for teletherapy and discuss the case with the voice therapist, and then they're going to obviously get to see the patient as well. And then we'll just stay in constant communication. But we don't have everybody on the screen at once.
Dr. Rubin, I'm interested to know what your actual evaluation looks like, with a limited physical exam and lack of video stroposcopy. What are you doing differently to get the best information through telemedicine?
I use both ears this time. You're going to get a history, which is always when I'm listening to the voice anyway, in reality and in truth, as I'm sure you all feel the same way. While you're getting the history and listening to the voice, you're trying to get a sense of what the problem might be. Is it a vibratory problem, a closure problem, so forth, and all the details from the history you can get. You can do after a complete history, you can do a kind of perfunctory head and neck exam, barely, obviously, but you can look at them and how they're using their voice, and then I'll often have them do some phonatory task. I'll usually have them do a glissando on an A vowel with a mezzo piano and listen for break and passaggio, those kind of things, listen to their range. I might have them sing for me if they're a singer, those are the basic things, and then at least get a sense of what it might be, discuss with them what it might be from everything you've gathered from the history in your ears, and obviously tell them we can't be certain that this is diagnosed. At some point you'll have to come in once things are safer, but can get started with therapy, and then we'll talk, we'll communicate with the therapist and discuss what we think might be going on, and they can take it from there in terms of therapy techniques. Established patients, similar thing. You know what's going on. You know what their treatment has been. You can still put them through similar tasks and see how they're doing. So.
For us, Amanda and I were talking about, we're going to get the history together. A lot of times we go into the room at the same time anyway, and feed off of each other in regard to history, and, whoever does the exam, but then the speech pathologist working with us will then take the patient across the way to do their full evaluation. And so, we're going to be trying to figure out, while I'm looking into maybe their past medical records, like checking something, Amanda's going to be doing some trial therapy.
Also,
yeah.
It's important to assess the severity, right? And suspicion for something significant that really has to be dealt with more urgently, obviously, And we still occasionally, like I said before, if something seems urgent, a little more ominous, then we will end up seeing them in person.
Sure. And Dr. Gillespie, I want to hear from you from a speech pathology standpoint. For your evaluation, same question. Since you can't rely so much on video stroboscopy, have you found that you're using any different tasks or tools or anything that you're relying on more than you had previously?
I don't know if I would say relying on more, but I think doing telemedicine is really showing us how important our stimulability testing is, because it's really all we have to go on now. We might suspect, I think this patient might have benign vocal fold lesions, but we have no way really to see, how big, how bad, how ugly. And so it's now really a question of, do we think this person is appropriate for voice therapy, spending a lot more time maybe working with them, trying to just determine not only what do we think is going on from a pathology standpoint, but really, is this somebody that we should be enrolling in voice therapy? So I think our eval, we can't rely on things like looking at acoustics, looking at aerodynamics. We started to play around to see if we can do a little bit of remote acoustic evaluation over telemed. We haven't brought it out for prime time yet, but we're kind of playing with it. But it's really a lot of, as Jeanne was saying, trial therapy, stimulability, and then getting back with our physician colleague and giving our opinion.
Great. So moving on to the next question, we touched on this already. We kind of have an idea of what your workflow is for telemedicine at your different institutions, but I'm wondering, we had a lot of trial and error. What were some of the main barriers and challenges that you faced, and what have you learned? What are some pearls of wisdom for helping a telemedicine workflow run smoothly? Dr. Gillespie, how about you?
Well, I think patients are used to calling, saying, hey, I have a voice problem, and the person on the other end of the phone says, sure, come in at this day and this time, and then they show up. And now at least in our office, it's been somebody calls or they're already on the schedule and we're determining we think they would be appropriate for telemedicine, and then someone else has to call them, try to get them on the phone to set them up with Zoom, and then somebody else is calling them the day before to make sure they remember how to get on Zoom, make sure they haven't lost the link and the ID, and then we're getting on the morning of and having to, or day of, and walk them through, no, the mute button's in the bottom, no, okay, now you gotta, yep, press that button, so there's the technology, but also it's just a lot of contact. So I think patients are probably now getting called like 3, sometimes even 4 times before the visit, whereas before it was one time. You call, you get your appointment, and hopefully you show up. So just figuring out that part of our workflow has been a little bit of a challenge. Like, how long can you go between setting somebody up on Zoom and having them do their visit without them forgetting how to use the technology? I think initially we were too far out, like 2 weeks is too far. One day before, and the patient starts getting a little frantic, like, I don't know what I'm doing tomorrow for my visit. So somewhere in between there. And in terms of just setting up our own schedules, building in that time, I know it feels like it should be so easy because we're just sitting in this chair. We never get up. We don't get people from the way, you just sit here all day. But there's just more time. The time in getting the patient set up, time in even the documentation seems to take just a little bit longer, trying to make sure you're crossing your T's and dotting your I's with your billing, or putting everything that you are putting in your notes about that this was a telemed visit, and kind of checking all of those boxes. So I think for me, what before was a typical like 45-minute visit is taking about an hour now. So I just have to be more mentally prepared for that from the therapy side of things. Yeah, and then like Dr. Hatcher said, just trying to get our how we're running our interdisciplinary clinic kind of ironed out. We realized there's a reason that when we're in clinic together, we go into the room together and ask questions together. And when we initially started this and we were separating it, it just felt so redundant that she sees a patient, then she has to talk to me about the patient, and then I go see the patient, but I'm still kind of asking them the same questions.
Mm-hmm.
So now we've put that together. So I think something has changed every week. It's still changing. So we're definitely not relaxed, I don't think, in the process, despite the fact that we're seeing a decent number of people now.
Yeah. From a physician standpoint, I've made all of my telemed visits 30 minutes, whether they're new or follow-ups, just because it's allowing for a little bit of a cushion between somebody trying to figure out their IT issues and all that kind of stuff. So I've just made them all 30 minutes. It all kind of evens out. I tend to catch up at some point.
Great. Dr. Rubin, anything from your standpoint in terms of like provider schedules? What makes your medicine run more efficiently? Do you have them interspersed or separate?
It's interesting. I guess we're not quite as organized as you guys are, but it doesn't seem to be causing a major problem. I typically, they schedule and they say you're going to get a Zoom link at the time of your visit. So I usually send it there, and it doesn't seem to be a problem. Occasionally, if no one's answering, I'll have the front desk just call them, and everyone's at home. No one's running out for lunch or anything like that. So so we're not quite as sophisticated that way, I think, but it seems to be working fine.
Do you intersperse your clinic visits, or are you is it all telemedicine all day?
Well, like I said, we're only seeing urgent or emergent things in the in the clinic. So, and those are we're very restrictive. So it's few and far between. I actually the biggest logistic thing is when you're dealing with not to be an ageist here, but when you're dealing with the elderly. It's sometimes, particularly they only have an iPhone, trying to get them, as a physician, we're still trying to do a perfunctory head and neck exam for, so trying to get them to show you their oracle sometimes can be a little tricky, with the phone. And I still can't get a good oropharyngeal exam. I don't know if anyone has any tips on that, because I can't get the light.
Yeah, I'm only in clinic on Mondays, ideally, and seeing airway patients, and then doing telemedicine, and then I do telemed Wednesday and Thursday.
Right. Yeah. I think that was one thing we tried to do one clinician a day, and a couple clinicians tried to intermix their telemedicine visits. And I find that telemedicine is a little more rigid. It allows for a little less flexibility in terms of time, just because people are logging in with an expected. And we have a support staff of the MA who checks in the patient, does a little tech support, makes sure they're logged on with Zoom, make sure that's all working, even puts in like a temperature if they're ready to go. And and we had a very well established telemedicine program before, not in the department, but at University of Washington, who has a whole website with these job aids for patients and consents that you can direct them to with their initial invite. So it makes it for pretty efficient process. But we found that separating the telemedicine does make a difference, and having a support staff of like an MA or someone checking in really does make things flow a little better.
But I still find, whether I'm in clinic for real or telemedicine, I still run an hour behind by the end. So.
I think the thing though to keep in mind is that for the patients, I mean, I don't know what you guys have heard, but even when the calls are dropped, or even when you're a few minutes logging in, or like you just forget, which happened to me once because I don't know, there's nobody to say like your patient's waiting. And they're so grateful. They love it. We've had no shows, and I mean, because like Adam, like you were saying, where are they going? Nobody's going anywhere. So they're coming to their visits. They want to do more. Every single patient has said, when the pandemic is over, can we keep doing this?
People are craving human connection right now. So I completely agree. And even the new patients, I find at this, they're just so appreciative of that someone has gotten on, face to face with them and at least talk to them about their issues.
And
a fair bit on telemedicine. I mean, you certainly can, assess the urgency of the situation. I mean, even with the airway, I had a couple dilations. I was we're on a schedule that we cancel because I talked to them and listened to them, and it could say they can wait. So.
Mm-hmm. Well, I was going to say, even with trying to figure out your workflow, I think as this talk is showing, it's not going to be the same for everybody. And I think a lot of people want to say, like, just tell me exactly how to do it. But the best way to do it is just start troubleshooting and be flexible and like take a deep breath. Because everyone's going to mess up. And so I think you just have to figure out what's going to work for your practice and not say like, oh, well, Adam Rubin is doing it this way, so that's the way.
No, that usually is what they say, but this time I wouldn't.
Yeah, got it. Right. Or the opposite, I think. No.
Absolutely. I think we actually already started to touch on this next question, but Dr. Hatcher, I want to hear from you. What patients do you think are the most appropriate for interdisciplinary telemedicine? Who have you been seeing in this way? What patient populations do you think lend themselves better for interdisciplinary telemedicine?
For interdisciplinary, actually, I feel like the follow-ups aren't as much because they've probably already had therapy. And so we're going to re-examine them, take a look at their lesions or their vocal folds and decide what to do procedurally. So that one may not be as much. But the new patients, I feel like that is a slam dunk no-brainer. And it doesn't matter if it's a breathing problem, a voice problem, or a swallowing problem, because we can both evaluate the patient in regards to their history, symptoms, go over what studies they may or may not already had, and all that. So I think that this is personally, and Amanda and I have talked a lot about this, it's going to be a huge way to triage patients into making sure we know what exactly is happening with them before they show up in clinic.
Mm-hmm.
Absolutely. Dr. Rubin, have you noticed any patients in particular in terms of populations or diagnoses that seem more appropriate or that you feel like you can do a better new patient visit with versus other populations you might tend to avoid doing telemedicine with?
I don't know that there's anyone I would avoid offering a telemedicine appointment to. I mean, I don't know how you could, decide that. I mean, I guess I don't do a lot of pediatrics, so I mean, but they still have the parents there to take, to show things. But I don't know if there's anyone I would not offer a telemedicine visit to if they wanted that.
Great. And
you talked a lot about trying to do a head and neck exam, which a ton of folks are doing. Personally, I'm just billing based on time. So, I mean, I look at it as the same as if you have the video capability. If I'm going to have a 25-minute conversation with you on the phone, if we can have that same conversation this way, then it's a whole different experience. So,
yeah, I agree. But you can make the medical decision making for return visits. So if you're prescribing something or changing medications, it can be pretty helpful. I find it very helpful for my cough follow-up patients if we're manipulating neuromodulators or something like that. I find it very easy to get to a level 4 based on medical complexity. But, time is going to be the major way because a lot of people have said you can't get to the level of complexity more than a level 2 for these visits for physical exam. So, but I do find that for these long complex histories, it's actually very helpful because you're spending most of the visit focusing on the complex history. And after you've realized that there's no urgent factors, there's no weight loss, there's no referred otalgia, there's no, there's nothing that they need to come in ASAP. You can start some of the workup based on the clinical findings, and then you can do your stroboscopy to help guide your next step, once this is all hopefully blown over. So I find it very helpful for my medical laryngology patients as well as my cough patients, especially cough patients who I really don't want to have them come into the hospital setting to be evaluated. So,
Dr. Rubin, you looked pre-verbal, as Al Marati would say.
Yes. The question is, can I remember what I was going to say? I think that I agree most of the time it's by time, but you can, particularly if you use the 95 guidelines, you can, it's not as restrictive as the 97 guidelines, so you can, code an appropriate level for a complicated patient you're going to recommend endoscopy to, right? So, and the other thing is, I'm sorry, don't misread me here, but this is a great service for the patients, but who knows what the future is going to hold here. I think people are going to be less likely to want to come into the office. Your product, think of all the times you stayed after till, whatever, 2 hours after making phone calls that were not, paid for or things like this. I mean, I think that we need to think about those things in terms of maintaining productivity and things like that.
I want to move on to our next question. It's actually a question I have been thinking about a lot more lately with our increase in telemedicine. You know, prior to the COVID-19 outbreak, otolaryngologists weren't necessarily prescribing reflex medicine without laryngoscopy. Per ASHA guidelines, speech pathologists weren't initiating voice therapy without an ENT visualizing the larynx first. So I want to know, you know, in our current state of emergency, do these guidelines still hold? Or are you comfortable prescribing or recommending some of these therapies? Dr. Rubin, what do you think?
Well, listen, I am a firm believer that when you're seeing a patient, voice patient, let's start with a voice patient, and you're getting the history and you're listening, the most likely way you're not going to miss a diagnosis if you know what you're looking for before you go in there. So I do think, I mean, I don't have great comfort not seeing the vocal folds and sending them in, but I do think that you can get a lot from that initial history and listening, and still, you know, discuss with findings and make a plan for behavioral therapy or sometimes medical therapy, just empirically. And you're gonna tell the patient that this is what you're doing. You don't have a definitive diagnosis. This is your hunch. These are the things it might be. And then you can see their progress up until the point you're actually going to get to look at their vocal folds.
And Dr. Gillespie, from a speech pathology standpoint, do you feel comfortable initiating voice therapy without laryngoscopy ahead of time? You know, are there risks involved there, or does the benefit really outweigh the risk for currently?
Yeah, I think the benefit definitely outweighs the risk. I mean, we have to keep in mind that, so the guidelines are in place because no one ever wanted to have someone go to voice therapy for, you know, months and then realize, oh, just kidding, you actually had papilloma, or you know. So a couple of things: we shouldn't be keeping people in voice therapy for months if we're not hearing a change. So I think, if the patient is not stimulable at all, so in your evaluation, no matter what you do, you cannot hear a change in the sound of their voice, they don't feel a change in their voice. Let's say you do one, maybe we'll be generous and do 2 additional therapy sessions. If you are still getting nowhere, you shouldn't be continuing therapy. You shouldn't be continuing therapy if you have seen the larynx and you're not getting anywhere in a couple of sessions, right? So there's this, now that we're in telemedicine, there's a crying kid in the background. Sorry guys, if you can hear this. That also happens in telemedicine. So now that with telemedicine, you know, the old rules, of course, were your telemedicine visit had to be equivalent or superior to what you would do in clinic. But we have to keep in mind that right now what we would do in clinic is nothing, because we can't bring these people in for voice therapy in the clinic because of COVID. So I think it's very easy for us to make a case that what we are doing in voice therapy is superior to doing nothing. So in that sense, yeah, I have no problem now seeing somebody for voice therapy who, where we haven't seen their larynx, especially if, as you guys all said, we've determined that there aren't these red flags. There's not something major that we would be bringing them in because we're concerned that it's an urgent or an emergent case.
Absolutely. Sounds like limited therapy can even be diagnostic in this situation, which
yeah, absolutely,
is helpful in and of itself.
Yeah. I think I've been like a complete nerd with this and been more going through a differential than I probably used to, because I can't see the larynx. So I can't say, oh, you've got a hemorrhagic polyp. I'm like, well, it could be this, it could be this, it could be this. These are unlikely. This is more likely. We'll go this route and figure it out from there.
Absolutely. Great. And now for the question that we all love, billing questions. I want to know how your different institutions are navigating the complexity, but more importantly, the ambiguity of billing guidelines during this time for telemedicine. Dr. Rubin, we'll start with you, since I know private practice, you do tend to get some more immediate feedback on some of these concerns. So how is your institution handling this?
Oh, yes, that's an advantage. We have a big practice, but we're one big family, and we have frequent meetings, Zoom meetings, and discuss what's going on and understand these things are changing frequently. There are definitely some basic principles that you should be aware of. And I think it's important for physicians and clinicians, speech pathologists to understand the billing to at least to some extent. Maybe not every modifier out there, you know, you can leave that to your billers, but you should have some sense, and you should talk with your billers, and you should follow and see if things are getting paid for, and you know, you should keep up with that. I mean, ultimately the clinician is responsible for the accuracy of the billing, first of all, too. And also you want to make sure that your department is going to keep supporting you if you're doing a lot of free work. So frequent discussions, frequent, you know, checking your state medical society. They're always doing webinars, things like that. You can stay on top of it. And I'm sure your hospital is too. I would expect your hospitals are as well, you know, doing frequent webinars and things like that.
Yeah, it's a University of Washington. They're very much, you know, use the guiding light of taking care of the patient and what the patient needs, and then, you know, whatever can't be figured out on the billing side of things, we hope that at least, you know, we did our best to take care of the patients as our primary motive, and then the billing issues will eventually, hopefully, work themselves out. You know, and there's some hope that maybe some of these new rules and regulations will be retroactive, and some of the work that we're doing, if it's not getting paid for immediately, maybe down the road can be. But I mean, again, nobody knows, it's evolving. So I think making sure that we use the guiding principle of taking care of our patients, we hopefully should not get into too much trouble from a billing standpoint or compliance.
All right, so I want to move on to our last question for our panelists. Where do you see the future of interdisciplinary telemedicine visits? Do you think that telemedicine will stay just as prevalent in the future, or do you think that it's just going to be considered kind of more of a stopgap for the current crisis? I kind of want to hear from all the panelists. Let's start with you, Dr. Hatcher.
Yeah, I think I'm hoping anyway that it's here to stay without all of the rules and regulations that were beforehand. I mean, we've been trying to do this now for a couple of years, at least for teletherapy, and it was such a hassle that patients didn't want to do it. Again, I think for new patients, screening, getting a history, figuring out what you think might be the issue, especially depending on your setup, when you have different laryngologists and speech pathologists that have different niches in regard to surgical management and or therapeutic management, you know, then getting them in with that person as best you think is possible. I think that that's, for us, I mean, the golden ticket that I can see. So I hope it's here to stay.
Great. Dr. Gillespie, what do you think about our future, not only for kind of the distant future, but also in this kind of post-surge, pre-vaccination era?
I think, well, one, I agree with Jeanne. I really hope that we're able to continue to do this. I think that it's on all of us right now to do the best we can to at least collect data, to be able to give back to insurance companies outcomes. There are some studies out there looking at telemedicine. There's definitely not a lot. So now's a great opportunity for everyone to get involved to do that. So I'm hoping that we're able to kind of lobby CMS, insurance companies to continue to support these visits. I think that, it's great that right now we're able to see these people. It's hard to say, what are we going to do post-surge, pre-vaccination? I think, honestly, it's a dramatic statement, but I think our entire field is going to change. I mean, we're seeing that, ENT procedures are some of the highest risk when it comes to COVID. I think the way we do everything is probably going to change. I don't think we're going to be scoping everyone in the office anymore without either some kind of barrier or testing the day before or something like that. Maybe we use telemedicine as a way to triage, as we all were saying. You spend time on the phone, everybody has one telemed visit, and that's where they triage their patients for who they're going to bring into the clinic the following week. I just think now it's kind of an exciting time for us to really get creative and figure out how do we want this to look, and then push our institutions and do whatever we can. And I don't know what that is, but to try to get insurance companies to be on our side with this as moving forward.
I think Dr. Gillespie said it before in the presentation that I think the primary reason that this is here to stay is because patients love it. Patients love being able to do this from their home. People who are still working love not having to take an hour off each side of working to have to come in for their visit and their evaluation. I think that, you know, this is something that's been catalyzed by the urgency of the situation, and I think people are going to love it. I mean, there have been other urgent, you know, changes that have happened to the way that we do things that people don't love, like who remembers not having to take their shoes off when they go through a flight and the security, right? And nobody loves doing that, but they do it because they realize the benefit of it. I think that that patients really love it. So I think I hope it's here to stay, and I think that that'll be the primary reason behiin it.
On the other side of things, people are going to be less wanting to come out, you know, and come into a medical environment, I think, too. You know, they talk about with this whole thing, the hammer and the dance. So we're doing the hammer right now, and then the dance. See, how do we, you know, merge what we used to do with what we do now? From a multidisciplinary aspect, at least you can be in the same office as your voice pathologist or laryngologist. So even if you're doing telemedicine, you can, makes it easier, you know, that way to discuss things. But it's going to be interesting for sure. But and hopefully the insurance companies will be wise enough to keep it going. They'll probably realize it's less expensive, and that'll motivate them. So
Yeah.
Well, the other thing I think is if there's a way to show that access to care was increased, not only just for the people who would already be coming in, but for people who, for whom transportation is an issue, you know,
there's no question that we've lost people that did do therapy because
100%. Yeah.
And I think for therapy, it's a huge bonus.
Yep.
Absolutely. Well, thank you. I love hearing about what telemedicine might look like in the future. Hopefully we can all continue trying to help affect change and do our best to lobby for change. But at this time, I'd like to see if Dr. Johns has any burning questions from the audience for our panel.
There's been some great activity in the question front, and thanks to the community for answering each other's questions. A good number of them have been covered and touched on, at least in the panel discussion, but some others that are out there. Prompts, questionnaires, what are you getting beforehand? How are you getting the answers?
So we're trying, we're trying this. So we, in the first week, I just sent my patients via Zoom. So through Zoom, you can send documents. So I just sent them a Word doc of the patient-reported outcome measures that I wanted them to complete, and just gave them a few minutes to sit there and do it. And then they just highlighted in the Word doc and sent it back to me. That's fine if you're seeing 3 people in a morning in the first week of this, but when we're all, as we all get back up to our normal caseload, that's not gonna work. So in our office, we're playing around with now either having the person who schedules the visit send the outcomes. Again, that kind of runs into the, like, how early is the visit scheduled and things get lost. So that wasn't really working. So now we've transitioned to having the MA before the initial clinic visit, so not before the therapy visit, but the visit with the physician and the speech pathologist, having the MA give those questionnaires at that time if they're calling the patient about half an hour before. So again, it's one of those things, we're playing with the workflow, but yes, we need those, especially if we're going to do any research and show that we're actually making people better this way. Yeah, so we're working on it. So if anybody, or I don't know who asked that, or if any other clinics have figured out how to do that, let us know. Let me know.
Well, I think that the major benefit of the telemedicine revolution is that every patient is being motivated to get onto their patient portal. And, you know, Epic, I mean, we have Epic, so, and that's what I know best, has a lot of provided ways for patients to do electronic questionnaires that can be sent out before visits. We've been focusing on getting the telemedicine up and running, that we haven't had the opportunity to send those out, but excuse me. The capabilities definitely exist, and it makes reporting and research a lot easier when they're already in a flow sheet that you can just do a report on. So we'll see. Any other questions?
All right, phone versus video. So telephone visits are now covered. Thoughts on that, reimbursement rates, ups and downs, things of that nature?
Well, I think just a patient care standpoint, it's much better having the connection to the video. I mean, all else things being equal, there's no question. I mean, certain things, if you're following someone for an urgent cough, I mean, that's not, you know, you could easily do that on a phone. The phone visits will reimburse less.
Yeah, I think with telephone visits, you also can't do a new patient because you have no idea who they are. Someone chime in and correct me if I'm wrong, but I feel like for telephone, it's only for established patients, which makes a difference. So then it, you know, cuts out all of the new patients that we can see in this mode.
They may have waived that requirement as well, but it does make it a little more challenging to
I would have a super hard time with that. Like, I mean, yeah, you can say it's your name and date of birth and your address and go through your identifiers, but having never seen the person, I personally would have a hard time with that, but that's me.
Yeah, I don't know that I want to do a new patient on the phone. I agree with you.
What if it's a phone visit primarily for the purposes of triaging for whether they need to come in for an in-person or not?
Still want telemed.
I mean, it's like if you're on the phone with them, have them push the FaceTime button, and now it's an actual telemedicine visit. Just look at them and talk. You know, and you're right, the reimbursement is much greater. You actually get to see the person. Yeah, if they can, just push that button.
By the way, you brought up an interesting point, Lisa, in that we put together a list, and I think other places have too, of things that need to be seen in the office. So we trained our front desk when they answer that call to, you know, to triage that, and they can check with us, you know, obviously, but that's where that starts.
Quick rundown. How long are your times for your MD, new and return, speech pathology therapy, and the interdisciplinary? How much time are you blocking in your schedule for those?
I'm doing 30 minutes for news and follow-ups right now, and that'll probably change for follow-ups later, but all of ours are multidisciplinary, so.
We started at 40 just to make sure that we could get the logistics set up for both new and return visits, but now we're moving to half-an-hour visits, just like Dr. Hatcher, and we're trying to do all of our visits multidisciplinary at this time.
For speech pathology here at University of Washington, ours are 60-minute appointments, but we'll see how that changes as we get a more efficient workflow, but 60 minutes is pretty good for us.
Same.
So I haven't changed mine, which has been 15-minute slots, and I just run late. But you know, it's not like the clinics are packed like they are, you know, normally. I don't know about the rest of you, but it's not so it's not as dire. If it's a 15-minute appointment, it takes 25. It's not the end of the world.
Yeah.
We've also been using NMA to help streamline the process for rooming for remote therapy. So we'll stagger two speech pathologists so that one MA can handle rooming both of the patients and help with tech support and stuff to really make sure that patients are on and ready to go when their appointment starts.
And are the people doing multidisciplinary same time? Are you doing it from each person's there in the office, or are you doing it from home?
Home.
Good.
Yeah, as long as you're using the same Zoom link, so you just pick whose you're going to use. But Adam, it sounds like yours is going to be different per visit, whereas mine, it's the same for every patient.
Right.
Yeah, and we use a secure chat through Epic that we just rolled out to talk back and forth, or we put them back in the waiting room if we want to have a lengthy discussion.
It's a great way to make sure we're staying physically distanced from our colleagues as well.
Yeah.
Dr. Johnson, we might have time for maybe one or two more questions.
Okay, all right. Fatigue. How are you managing fatigue? Voice fatigue, eye fatigue. This is real.
Impatient position.
The eye fatigue is a real thing. I'm not wearing my glasses now because they reflect, and I thought it would look weird on this, but by the end of the day, it's bad. I think you got to get up out of your chair.
Yeah.
Yeah, you have to like set a timer, get up, walk around, go for a walk. open a window. It's amazing because, you know, I don't think we're talking more than when we were talking in the office, but just the sitting and staring at the computer screen all day, I find this to be very tiring compared to being live in person. I don't know if you guys feel the same way, but I'm beat.
I agree. And I think for the vocal fatigue, I find that wearing a headset or having some sort of microphone helps me, because if I don't have it, I feel like you're on speakerphone with the phone. I feel like I'm shouting.
Screaming.
I don't need to shout. So using the microphone is helpful in that respect.
Yeah, don't underestimate a good microphone. I've got my Yeti here and a good headset, as well as a good internet connection, so you don't have to repeat yourself over and over again. Those are all helpful things. And I actually think the multidisciplinary clinic is really helpful because you can take turns asking questions and documenting, and it gives you a bit of a break.
Interesting. I find it easier. Maybe it's because I'm not as, it's not as busy as my normal clinic. So it's just a different opinion,
Also, Lisa, with the sound, I hear people on the radio saying like they're recording from their closets now. So I started to actually put a pillow on either side here of me and right behind the computer, just to help eat up the sound a little, because otherwise it's just bouncing off walls. And so that has helped a little, and I feel like I'm shouting less.
That's a great idea.
By the way, this point probably doesn't need to be made, but they released the need to use these HIPAA compliant forms of it, but you still have to be HIPAA compliant in that you have to be alone in the room. There can't be anybody there with you or behind you.
Yeah.
And careful when you're sharing your screen to only have one patient up.
Yeah. I haven't done that yet because I don't know. I don't trust myself.
I found it to be pretty helpful to go through some of our handouts for titration and Gaviscon, buying it online or something.
But that ability, if you can.
How many patients are you guys seeing in a day?
I think we have a half-day block of 8.
We're still ramping up.
Yeah, for multidisciplinary, that's probably like about.
Yeah.
Well, I would like to be mindful of everyone's time here. We're about at that time. Thank you everyone for a great discussion. If you have any more questions or comments or want to continue, we do have the Eat, Breathe, Talk Fall Voice online community, so we can continue the conversation there if we want to. Thank you again for all of our panelists for joining us tonight. And thank you out there to the Fall Voice community. And I hope to see you all at the Fall Voice conference in October.
Hopefully we can all go.
Exactly.
Right.
Yeah, seriously.
We will. We will.
Everyone.
Thanks.
Thank you.
Take care. Bye, everyone.
See you guys.
Bye, y'all.